So these are the pulmonary arteries and pulmonary anatomy. Obviously, you should all be aware for this from all the different USMLEs, et cetera. This is PE. We can see both sides here bilaterally on this 3D reconstruction. What we're worried about is affecting the right ventricular function because of PE as blood and pressure starts building up and starts backing up into the right heart. We talked about on the ICU lecture, we talked about the RV and echo. So this is from the European Society of Cardiology 2019 guideline. The document has everything you want to know about VTE. It's an incredible read. And honestly, just looking at the pictures and the tables, you'll know more than enough to treat PE in all its forms. So we see all the different kinds of echo signs that are related to PE. Here we see the normal heart versus the dilated RV because of the RV dysfunction caused because of PE, which triggers us into the spiral of death. Against this famous diagram of how the pathophysiology of increased RV function and then dysfunction, reduced output, and cardiac output relating to obstructive shock and death. We try to cut it off here. Once we see the RV dysfunction, we try to prevent it from getting to the left heart and systemic pulmonary hypotension, systemic blood pressure reduction. That is called massive PE. When we have sustained hypotension from less than 90 for more than 15 minutes, or pulselessness, or patients on pressor, or found with arrest and had CPR, that's called a massive PE. A saddle PE is not a massive PE. Massive PE cannot be diagnosed on radiology on a CAT scan. It is a clinical diagnosis. Here we see what a saddle PE is. It's just a PE that reminds us of a saddle because it's bridging the main pulmonary artery bifurcation. That's all it is, nothing else. There's studies talking about central versus peripheral clot correlated to mortality. This is a study, you can look it up later. It found that there's no correlation between central or peripheral clot to mortality. So all bets are off. Saddle PE has no clinical significance. What we're interested in is the submassive PE territory, which is there's RV dysfunction on CT or ultrasound, and there is elevated cardiac enzymes. It used to be BNP, now it's mostly troponin, including high sensitivity troponin. Those are kind of by the wayside. When we talk about massive and submassive PE, but when you actually try to risk stratify patients, the European breakdown of high, intermediate, and low, and where intermediate breaks into high and low. And this is based on the PESI scores, some kind of RV dysfunction or troponin leak, or both puts you in the intermediate high risk, which is where we're most interested in, to prevent people from going to high. This is the PESI score. I'm sure you're all aware. The PESI score is almost impossible to do. The SPESI score is a little easier. You can refer to that later. This is, again, from the 2019 European guidelines. This is the breakdown of the algorithm of who should be treated at home, who should be hospitalized, and who should get some kind of reperfusion therapy. We're not going to focus on this. We're going to focus on this area. So the most important thing we can do for an acute PE patient is give them enoxaparin, low molecular weight heparin. This is a study from MGH that shows that when we give them heparin infusion, so unfractionated heparin infusion, only about 50% of the patients within 24 hours reach therapeutic levels, which is unacceptable with PE. Those first 24 to 48 hours are critical. We want all of them within therapeutic range. So Lovenox beats heparin on this. But the question always comes back, what are we going to do if there's a procedure? Is it safe putting them on Lovenox, which we can't reverse easily, compared to heparin, which we can just stop if they're going to get a procedure? So a little shameless plug warning, we published this article about 156 cases of a catheter-directed thrombolysis, all of them on therapeutic Lovenox or heparin, and found no increase in bleeding, hemorrhage, or any kind of adverse event, actually. So we're now, after we said, give everybody who can the intermediate low risk heparin, now we're going to focus on intermediate high risk. Endovascular thrombectomy for PE breaks into two: thrombolysis, where we melt the clot away, and thrombectomy, where we aspirate the clot away. Focus on thrombolysis. This is the ECOS device, which emits ultrasound waves on top of the TPA, which helps break down the fibrinogen network here. Has the most data behind it. You can peruse these later. This is the multi-side hole. This is the unifuse catheter, and also the Craig McNamara. It's very similar. On top is Craig McNamara. This is the unifuse. They just rip TPA. Some people do it with pigtails, just pop the pigtails and the proximal and let the TPA go. Also functional. We know that around 14 to 24 hours of TPA. It doesn't matter if you use ultrasound or not, they get the same results. This is a Thrombolytics Bashir catheter, which is kind of a hybrid. It says to create some fractioning of the clot with this kind of network of catheters that break out, and then shoots the TPA from the periphery rather than from the center. This is just all kinds of different lysis protocols over the years as they got developed. You can use this later for your reference. Thrombectomy devices, we're all aware of the Inari flow retriever, comes in 16, 20, and 24, has all kinds of configurations, has all kinds of thrombectomy devices, stent retrievers, and of course the Flow Saver blood auto transfusion device. We've all seen this on the internet. I won't belabor you. This is the Penumbra device, or CAVIT, which is a computer-assisted venous thrombectomy. It uses a computer to sense when it's against clot or in an open vessel to limit blood loss. These come in 16 French and different sizes, good for PE and IVC work. Some use it for leg DVT. Personally, I prefer the 12 for that. This is another procedure where we see no blood flow in the bottom of the left lung. And here we see after not all the clot's gone, but definitely reperfusion. This is the AlphaVac device, again, a 22 French device. Comes in all kinds of configurations and systems for mitigating blood loss. This is how it looks when it's all functioning and assembled. Case presentation. So we had a 75-year-old female with, the usual stuff, comes in with lightheadedness and dyspnea for about 3 days. She presented to the ED at night. Saturation was 88 on room air, but was better on nasal cannula, tachycardic, tachypnic. She was borderline hypotensive, but then kind of perked up without even giving fluids. The PESI is a class 5, SPECI is 3, which are positive, puts her intermediate risk. D-dimer was elevated, BNP was elevated, troponin was negative. So based on the classification, and this is a CT showing her PE, kind of extensive bilateral main pulmonary. Echo showed us right ventricular dysfunction and McConnell sign. Could not estimate the blood pressure. With RV dysfunction, positive SPECI, but negative troponin, she's intermediate low risk. Because of her persistent tachycardia, we decided to continue with endovascular thrombectomy. So the first angiogram we see of the procedures, obviously anybody who's seen these sees something wrong, because as we're injecting, what we're seeing is the aorta filling. So we were in the left atrium through a PFO that the patient didn't know that she had, and the echo didn't pick up, and saw the aorta filling up instead of the pulmonary arteries. Obviously, we retracted and made our way back in. What do we do at this point? We decided to keep going with the thrombectomy. Everything went pretty well. You can see the left on the left side of the screen, you can see the initial images, and then on the right, we can see better perfusion on all aspects. There's still some residual clot, but her pressure's improved. As we can see here, went from 43 to 34. Patient felt better. About 15 minutes after the procedure in the recovery area, she started developing expressive aphasia. Obviously, we triggered a stroke alert. CT of the head showed no acute findings. We saw an MRI. I'm not sure, move this here. We saw an MRI, and as you can see here, there's white thingings in the thingy, or as we call it, small areas of focal restriction diffusion on the FLAIR protocol, which means acute stroke. I kid about this because I've followed this patient for a year. She was discharged postoperative day 4 without any aphasia, and 1 year after, she had no long-term sequelae from the PE or neurological standpoint. So this case was a success, and the patient was happy. But it does lead us to think about, when do we choose thrombolysis versus thrombectomy? For our practice from now on, whenever we see a PFO, which can cause paradoxical embolus, we always choose catheter-directed thrombolysis. The risk of pericatheter thrombus or corking of the device, if it gets occluded and you have to pull it across the PFO with clot at the end, even small pieces, fragments of the clot that embolize may cause stroke. So we elect for catheter-directed thrombolysis for every patient with a known PFO. Just to kind of take everything home. If you remember anything from this lecture, is A, B, and C is enoxaparin, enoxaparin, enoxaparin. Everything else is secondary. Get the patient on anticoagulation and have it be low molecular weight heparin if possible. And the last thing, PE severity is a clinical diagnosis. I know we read a lot of diagnostic, and most of the people here, I hope, will go through diagnostic radiology training as part of their as part of their VIR training, and they will see that a lot of people still call massive PE and call a massive PE saddle PE, or the impression reads massive PE with a hard RV dysfunction. That's not a thing. Lose that from your lexicon. PE severity is a clinical diagnosis, as in VIR doctors, we're all clinicians first. Thank you. Any questions? Did I make it in 8 minutes?
You crushed it.
Yeah, Dr. Graif, thank you so much for your talk. And yeah, if there's any questions that anyone wants to kind of speak up and share, we do have a question that comes to my mind, a little bit on the side of this topic, but definitely related to PE. Is at your institution, if you have a PERT team, what is the role of the VIR doc? And if not, what do you envision the role of a VIR doc is in a PERT team?
So every hospital has a different PERT. The idea of PERT is having a fast, multidisciplinary discussion about the patient. In our hospital, whoever triggers it, we have an ICU doc and an IR doc 24/7 going on a conference call with the initiating physician. 80% of the time it's the ED, 20% of the time it's the floors, and that's where we discuss everything. This leads to an IR consult and procedure or not procedure. So that's how we visualize our PERT. Our IR docs were the initiators of the PERT in the hospital as the PERT committee and setting up that whole process, and we're part of the PERT committee in an ongoing fashion. So I think it's critical to be clinicians first. Without that, we cannot have a say in the well-being of our patient and our community. So that's key.
I had a quick question. I think Zaim brought it up. The kind of the concept of high sensitivity trope versus standard troponin, and is that an accurate assessment for PE severity?
So a lot of regular troponin tests are no longer available.
Right.
Most of the data we have about risk stratification is from regular troponin, which makes it kind of irrelevant. The EC guidelines talks a little bit about high sensitivity troponin. Data is forthcoming. There are trials that, depending on which study of high sensitivity troponin you're using, the threshold is about 0.14, I think. Now, there are studies that show that increase of troponin does not correlate, or decrease of troponin does not correlate with prognosis. So if one of them was elevated, obviously not in the setting of AKI, which can falsely elevate it, usually is positive. Some studies talk about age differences, so that older people have a lower threshold than younger people. Data is still a bit murky about that. Hopefully, with the next ESC guideline update, which is supposed to come out, I hope later this year, we'll have a better process of understanding that.
Yeah, you also brought up, like, in a PFO, if you have a clot kind of in the PFO, that you tend to prefer CDT with a thrombolytic agent versus kind of thrombectomy. Can you go over, is there data on that, or is it kind of your own kind of experience, or what's your rationale?
So my rationale is that circulating TPA lowers pericatheter thrombus, and the smaller the catheter, the less chance of pericatheter thrombus. The large catheters can create more pericatheter thrombus through thrombectomy, I mean. And sometimes when the thrombectomy catheter gets occluded, or a piece of subacute or partially chronic clot kind of dislodges at the lodges at the end of it, and you can't suck it out, you have to cork the whole thing and pull the entire catheter out to flush it outside the body. Pulling that may release fragments of clot along the way in the IVC or in the RA, and then can go through the PFO because of the increased pressure in the paradoxical embolus. So with catheter ductal thrombolysis, you just pass once. You put it in and you're done, and then it just stays there. So that's our rationale. There was one study that talked about PFOs. They looked at 11 patients that they did that with known PFO that underwent catheter endovascular thrombectomy with the Inari device, and one of them had a stroke. So out of 11, that's about 11%, 9%. So that's the only data out there.
I gotcha. And then when you get in there and you're measuring a PA pressure, either systolic or mean, is there a cutoff where you're like, this is a chronic PE and this didn't happen overnight? How's your algorithm for that? And what do you do? And what's your algorithm for that?
So you kind of know that when you're in and you're measuring pressure and you see the pressure is like 70 or 80, and you're like, okay, this is not sustainable. This is not, this is incompatible with life. It's obviously has to be lower. We still do thrombectomy because a lot of times the patient had chronic issues. Sometimes it's not chronic PE. Sometimes it's just chronic pulmonary hypertension because of obstructive sleep apnea or obesity or interstitial lung disease or fibrosis. So we don't wait it to go down for normalization. We try to see any kind of decrease in pressure, hopefully in vital signs as well. So we don't get it to normalization, but sometimes we can decrease it.
And what's your kind of mechanism of sedation, or is it just local because of these kind of intermediate or high risk patients? What's your algorithm?
So no propofol. No, no propofol. No, there's studies about this. Propofol kills this patients. There was, I think in JVIR, an article talking about general anesthesia for these patients, and it was correlated with increased mortality. Do not give them general anesthesia. If the patient is absolutely crashing and you have to intubate them, then get a cardiac anesthesiologist who specializes in cardiac procedures and have them do an intubation, which does not use propofol and does not use anything that will worsen the heart rate. Now, intubation on its own increases intrathoracic pressure, which then increases the pressure on the heart, which makes the RV dysfunction worse and can kill the patient. So just intubation is bad. So that's a last-ditch effort. We do most of our patients with moderate sedation, so fentanyl and Versed and Lido.
And then what about kind of right ventricular support systems or even ECMO? When do you incorporate, like, say, RV Impella or Prometra or a straightforward standard ECMO in your algorithm?
So they're not in the algorithm for the endovascular thrombectomy procedures in our hospital. We don't have them in the room. I know some places do that. We don't have those resources to have them in the room for every case we do. We usually reserve them for failure or for patients who have, issues with, let's say, we saw this a lot during COVID, where their lungs are just have a lot of airspace disease and have a PE on top of it, and just doing a PE won't help. ECMO can help in that case because it just oxygenates the blood and just bypasses the whole pulmonary system, heart and lungs, and just kind of so that's where I see it kind of come in.
Oh, thank you.